Well, hello and welcome to the CSF June monthly podcast. This month, 3 papers have been uploaded to the CSF website, and today I'm going to be highlighting 2 of these. Now, the first paper is one that follows from a paper we uploaded last month from Professor Prof Strand. This month, we're highlighting her second post-hoc analysis of oral start and oral scan, which analysed long-term radiographic and patient-reported outcomes from these studies. Now, quick bit of background for you. These were patients with rheumatoid arthritis. We know that early intervention with DMARDs in people with rheumatoid generally leads to reduction in the progression of structural damage. And previous studies have demonstrated that tofacitinib, which can be given at 5 or 10 milligrams BID as a monotherapy or in combination with conventional synthetic DMARDs, is an efficacious and safe approach to the management of disease. Now, this is a post-hoc analysis that looked at data from oral start and oral scan to examine the efficacy of tofacitinib on long-term radiographic and HAQ disability index scores. The analyses focus on the relationship between disease activity at month 6 and longer-term outcomes. So once you're into therapy, how do things go as time passes? Now, just a quick recollection, oral start was tofacitinib monotherapy in patients who were methotrexate naive. Oral scan was a tofa combination study in patients who were inadequate responders to methotrexate and who'd received stable background methotrexate. Now, the endpoints in this particular study include CDAI, DAS28-ESR, DAS28-CRP. Disease activity was defined into thresholds, remission, low disease, moderate disease, and high disease activity, respectively. Radiographic progression was defined as baseline changes in the MTSSS. Radiographic non-progression was defined as less than or equal to 0 change from baseline in the SHARP score. Physical function was measured as HAQ disability index scores, and a normative HAQ-DI score was defined as less than 0.5. So, key results that are in this paper: at month 6, more patients in oral start receiving tofa achieved CDAI remission or low disease activity compared with methotrexate. The number of patients achieving CDAI remission or low disease activity in oral start was generally higher than in oral scan. These, remember, are people with earlier disease. They have shorter disease duration, so that's pretty typical. Tofacitinib treatment was associated with lower levels of disease activity compared with methotrexate. And at 2 years, the mean change in SHARP score was smaller for patients receiving tofacitinib in CDAI remission at 6 months compared with patients in CDAI defined as moderate or high disease activity at 6 months. So some sense that by 6 months you've got a clue as to what might happen in future. Patients receiving tofacitinib monotherapy who were in a CDAI moderate or high disease activity state at 6 months were more likely to show no radiographic progression at 2 years compared with patients receiving methotrexate. So there's still a disease drug effect ongoing. And patients given tofacitinib with DAS28-CRP less than 2.6 at 6 months reported fewer normative HAQ-DI scores compared with patients in CDAI remission with DAS28-CRP less than 1.9. And more patients receiving tofacitinib who achieved CDAI remission or low disease activity at 6 months reported greater improvements in HAQ-DI at 2 years compared with patients in the higher disease activity states. So, key implications here: well, patient disease state at 6 months looks as if it's an indicator that might be useful when we're thinking about long-term disease progression inhibition and improvements in physical function. And there's some evidence that tofacitinib therapy reduces structural damage in patients across disease states when compared with methotrexate. Now, the second paper I'd like to highlight is a report on the effect of baricitinib on radiographic progression of structural joint damage at 1 year. Again, people with rheumatoid arthritis, this time who were inadequate responders to conventional synthetic DMARDs. First author here is Professor Desiree van de Heijde from Leiden. The backgrounds, again, as we've just discussed, DMARDs have as one of their key purposes the desire to inhibit structural joint damage. And in the 24-week RA build study, baricitinib was shown to significantly reduce radiographic progression of joint damage. Patients had active RA in this trial and were inadequate responders to conventional synthetic DMARDs. The study reported long-term radiographic progression of patients who completed RA build and enrolled in the long-term extension RA Beyond. Now, a quick recollection: in RA Build, patients were randomized to placebo or baricitinib at 2 or 4 milligrams and stratified by region and presence of joint erosions. Once completed, patients could enroll in RA Beyond, a 2-year phase 3 long-term extension study. The patients who enrolled in RA Beyond continued to receive the baricitinib dose they received at the end of RA Build. Placebo patients who were not rescued were switched to baricitinib 4 milligrams on entry to RA Beyond. Now, radiographs were taken at baseline, week 24 and week 48, and scored by 2 primary readers with a mean record calculated. Baseline radiographs were the initial radiographs taken at the RA Build baseline, just so that you get the studies in your mind. And radiographic progression was determined by the change from baseline in Heijde sharp score, in bone erosion, and in joint space narrowing. And the thresholds were used to determine progression versus non-progression. If the patient had rescued or had an early termination visit, radiographs were obtained if the most recent radiographs were more than 12 weeks earlier. And these patients were classed as non-responders. It's a fairly standard imputation approach. The occurrence and severity of all adverse events were recorded. So what are the key results? Well, of the 611 patients who completed RA Build, 583 enrolled into RA Beyond. At week 24, for patients receiving baricitinib, the progression of structural damage, joint space narrowing, and bone erosion was inhibited. At week 48, similar results were observed as those seen at week 24. However, only the 4 milligram dose of baricitinib demonstrated significantly less radiographic progression. Now, for patients given baricitinib, numerically larger proportions of patients had no sharp score progression when compared with placebo. And during weeks 0 through 24, the rate of adverse events, treatment emergent adverse events, and discontinuations were similar across the treatment groups. And from week 0 to 48, the most treatment emergent adverse events and serious adverse events were reported in patients receiving the higher baricitinib dose. And the implications here, well, both baricitinib doses were associated with reductions in the rate of structural progression. Baricitinib 4 milligrams presented more consistent reductions in structural progression than baricitinib 2, but these are as observed data in terms of the strength of the analysis, so one should be cautious in over-interpreting that. And the responses observed at 24 weeks for patients given baricitinib were maintained through 1 year. I think it's important that we look at further radiographic data to determine the longer-term treatment effects associated with baricitinib and to really understand the differences and similarities between the 2 dose groups. And final remark, the last paper we uploaded to the CSF website this month is a paper analysing how patient characteristics influence biologic treatment choice in people with rheumatoid arthritis. The first author here, Thomas Frizzell from the Clinical Epidemiology Unit in the Karolinska in Sweden. Now, don't forget that everything we've discussed in the podcast is available in more detailed format, slides and abstracts on the publications section of the cytokinesignaling.com website. And please also subscribe to our podcast channel and let us know what you think by reviewing the podcast. Thanks ever so much for your attention, and I do hope you found this helpful in your clinical practice.